I got it.
Okay, so this is our committee roster. I'm just kind of going to go down this in order, starting in the upper left, kind of work my way down and then to the right. But maybe it's better if we don't show that, just so we can kind of, can folks see one another? I'm not sure.
Yes.
But it might be better. Yeah, we just want to let, generally we're going to ask that people stay off of video just because it preserves bandwidth, but we'll kind of go down the list if you can come off and just introduce yourself. And I'd sent out a little note just saying, letting folks know this was coming. So we will start with Amy Penkin from OHSU.
Hi, good afternoon, everyone. My name is Amy. I use she and her pronouns. I'm the program manager for the OHSU Transgender Health Program. I've been with OHSU for almost 10 years since the inception of the program. And I think the prompt was, what are we hoping or expecting from this Rules Advisory Committee? My hope is that we have a universal understanding of how we promote access to gender-affirming care, reduce barriers, and maintain a lens of equity for our trans and non-binary communities accessing care. Thank you.
Thank you. Antoinette, are you available?
Yes, I am. Hi, good afternoon. My name is Antoinette Iwachi. I'm the Senior Public and Regulatory Compliance, Specialist for Cambia Health. Just wanted to, let you know that Regents has been covering gender-affirming care consistent with the prior bulletin, which is 216-1, and works to ensure that our members have access to medically necessary services. We engaged with the development of House Bill 2002 through early conversations with leadership and advocates for the gender-affirming care sections of the bill, and have experience implementing Washington's similar legislation. Our focus through the bill's development was ensuring that requirements for insurers were clear and implementable. And this is really a main point we want to make sure comes across through rulemaking, that the requirements for insurers, again, are clear and implementable, and that network adequacy provisions were reasonable considering the multidisciplinary scope of gender-affirming care services. So we're serving on the RAC to help meet these goals and make sure that the rules are clear, reasonable, and implementable for regions and its members we serve. Thank you.
Thank you. Chris Coughlin, excuse me.
Yes, Chris Coughlin, thank you. I use she, her pronouns. I'm the policy director with Oregon Consumer Justice, and OCJ joined this particular RAC with our mission of putting people first, and in particular in these conversations, looking at consumers' access both to care as well as issues around cost sharing and cost and so forth. So that's kind of the consumer lens is the focus that I'll be bringing to the conversations. So thanks very much.
Excellent, thank you. Do we have Courtney Dresser on? Courtney, are you there? We can't hear you. Maybe she's not available. If we could go ahead, Everett, are you available? Are you on?
Yes, I'm here. Can you hear me okay?
Yes.
Okay, great. Hey everyone, my name is Everett Redente. I use he and they pronouns. I currently work for Care Oregon as the transgender healthcare coordinator. I'm here in more of a personal capacity as somebody who is trans myself and also has been a provider, behavioral health provider in this space. With that in mind, definitely want to take my experience and inform and help and share some insight where I can. into this space and hoping to, similarly to Amy, reduce barriers and increase equity, hopefully reduce some gatekeeping throughout this process. That'll help folks in my community be able to access the care that they need. Thank you.
Great, thank you. So the next committee member is Glenn Bailey. Glenn is with OHA and the government relations team, and he specifically works with PEB and OWEB. Glenn wasn't able to be here today, but he will be representing both from the standpoint of the PEB and OWEB boards. They're affected by this in that, you know, they do have some fully insured health options for teachers and state workers that would be subject to these provisions, and also even on the PEB side, they do have self-funded options, but generally PEB complies with all of these requirements just sort of as a matter of policy. So Glenn will be with us for that reason. And then we can go next person, Jonathan.
Thank you. Hello, everyone. Jonathan Froxway, he, him pronouns. I'm the public policy manager for Cascade AIDS Project. In addition to being the oldest and largest HIV services provider in Oregon, we operate Prism Health, an LGBTQ health center, where about 1/3 of patients are trans or non-binary, 2/3 of behavioral health care patients. So an important provider of gender-affirming care. My goal as a member of this RAC is to ensure that the gender-affirming care provisions of House Bill 2002 are implemented according to the intention of the legislature, which I think was to make sure that trans and non-binary folks, anyone needing gender-affirming care, regardless of where they live across Oregon, is able to access that care without high barriers. Thank you.
Thank you. Merlene Converse.
Hi, my name is Merlene Converse. My pronouns are she and her. I'm a senior regulatory consultant at Kaiser Permanente. My goal in joining this rulemaking advisory committee is to support the needs of Oregonians to access gender-affirming services. It's really important to have a common understanding of coverage requirements for health carriers to be able to implement the requirements in a consistent fashion and provide Oregonians with a consistent experience, regardless of which health carrier they choose to get their insurance through. So I look forward to the discussions. I also, our company has experience in the state of Washington using the Washington regulations. And so I am intrigued that Oregon is going to consider a similar approach. So I will be looking to try and find consistency so that, again, there is, you know, ease of administration between both of the jurisdictions that we operate in. Thank you.
Thank you. Rick Blackwell.
Everyone, I'm Rick Blackwell. I'm the Director of Oregon Government Relations for Pacific Source. I'm here for Pacific Source Health Plans. We're just here to make sure that we vet all of the possible delegative or inexact terms or areas that the department is required to complete via rulemaking, making sure any commitments on the record are done through the process. The policymakers have spoken concerning what they would like to see in terms of insurance code requirements. I think it's all of our job just to make sure that we get that exactly right from the text and the context of the statute in front of us. So thanks.
Thank you. Scott White from MODA.
Hi, good afternoon, everyone. My name is Scott White. He, him pronouns. I am the Director of Regulatory Affairs for MODA Health, here representing MODA Health Plan. My main goal is to ensure that issuers obtain clarification through rulemaking needed to properly implement this statute in accordance with its legislative intent. As kind of piggybacking on what others have said, this allows us for issuers to facilitate consistent coverage for these services, which leads to a consistent member experience as well. So thank you for having me here today.
Thank you. Seth.
Hello, everyone. My name is Seth Johnstone. I use he, him pronouns. I work at Basic Rights Oregon as the Transgender Justice Program Manager. My history here is a 12-year coalition with trans folks across the state, establishing healthcare, which was banned only about a few years ago. So really working to make sure that our patients across the state have access to basic necessary care, and excited to dive into a little bit of the details to make sure that it's implementable. Thank you.
Thank you. And last but certainly not least, Tara Harrison.
Hey, thanks, Michael. Hi, folks. Tara Harrison with Providence Health Plan. And like other carriers here, just really interested in making sure that we get rules that are clear so that we can support these efforts to provide equitable access to gender-affirming care. And really interested in digging in on some of the challenges that I think carriers are going to have around some of those network adequacy issues, especially where we have members maybe in locations where access to certain types of providers might be harder to obtain. So just looking forward to the conversations and some of the problem solving that we can do through this opportunity.
Great. Thank you so much. Okay, if we can go to the next slide.
Real quick, I didn't get a chance to introduce myself.
Oh, is it?
Yeah, this is Aaron. So this is Aaron Waters. I use she, her, sometimes they, them pronouns. I am a program director at Black and Beyond the Binary Collective, which is a nonprofit which is focused on supporting Black and Indigenous, trans, queer, non-binary, intersex, and two-spirit individuals. I was also part of the group of humans who helped get the Kaiser Permanente Gender Pathways Clinic set up. I was a community health worker there at the time. I've also been a site specialist for Epicare, so I'm familiar with some of the back-end programming as well. My hope here is to just be a part of the conversation, particularly as a Black trans woman. I know that sometimes during implementation or development phases, sometimes we miss things, and I hope to be a part of the conversation so we don't, and we can make sure things are implementable and accessible across the state.
Excellent. Thank you much. And now, Karen, if you can go to the next slide. Okay, just want to hit on a few kind of housekeeping and talk a little bit about expectations. So we mentioned this earlier, so we do ask you keep the video off unless you're speaking. Doesn't have to be super strict on that, particularly. I know we're probably going to get to a point where we're talking back and forth, but it just helps conserve bandwidth. If you can also keep your lines muted if you're not speaking, that prevents any background noises or disruptions. You do have the raise hands function. So if you do want to speak, please raise your hand. That just keeps us, being that we are online, that keeps us just one person talking at a time. Make sure everybody has a chance to say what they need to say. I will do my best to monitor that and call on you in the order the hands went up. The chat window should be open for everybody. If you have anything notes you want to drop in there, please do that. I'll try to monitor that as well as I can. Just one thing to be mindful of, sometimes when we're sharing screens, I may not be able to see that. Also want to note, so one thing I did want to make clear for everybody is we had a lot of interest, obviously, in this community from all corners of the state. So we had to be maybe a little tighter than we might normally be about, committee members versus non-committee members, just in the name of trying to keep the conversation flowing. We did have some people that wanted to be a part of RAC. We couldn't get them on. We ended up capping at about 12 people, which is a good, solid number, about equal representation between payers and sort of advocates and sort of other interests. So we do ask that, if you're not on the committee, if you're not selected actually on the committee, if you can kind of hold any commentary for public comment, we will make sure we get to that at the end of, I think generally we're going to do that at the end of the meeting. But like I said, the chat is open. If folks, have just a burning need to say something sooner, we will kind of check in on that. Like I said, we're going to try to take a break about halfway through. So if anyone has anything they want to say at that point, we could probably open it up. I'll just try to monitor the time. That being said, if you are doing public comment, please be mindful of everybody's time. we've got a lot of viewpoints and a lot of ground to cover and not a ton of time. So if you can kind of keep yourself to maybe something around 5 minutes or so, that's always helpful. One other thing, I just want to make a couple other points I want to make. Just sort of a brief note on language. I think it's important as we move into this process, just make sure everybody's sort of mindful of kind of the language we're using to talk about these issues, recognizing that in the area of gender-affirming care, even words or phrasing that was used maybe 5 or 6 years ago sometimes is outdated. For my purposes, I'm going to use the phrase gender-affirming treatment. That is the language that's in House Bill 2002. Some people prefer to say gender-affirming care. Those essentially, I think, have the same meaning. Similarly, if we're going to use phrases like assigned male at birth, assigned female at birth, rather than something, say, like biological sex, right? So just try to be respectful and thoughtful about how you're speaking. I would note there's one thing we're going to talk about when we get into it is there's the WPATH 8 standard of care. And that has a very good appendix B, that does a really good job of sort of laying out some different terms. So just kind of be thoughtful of that. Kind of going with that, and this is really kind of the key expectation, is I realize we have sort of very different groups here, and very different thoughts and coming from very different perspectives. But I do ask that everybody kind of come into this with good faith, and try to be respectful and professional. We can't really have, we can disagree, but if we need to be sort of respectful and professional about how we do that. So, kind of one thing, one issue that is not on the table in this rulemaking is the question of whether health plans are going to cover gender-affirming treatment. House Bill 2002 answered that question, and the answer is they are. So kind of the way I'd like folks to approach this is with a mentality of, this is not a conversation about whether we're going to cover it, but how, right? So sort of a shared problem for all of us of what does health insurance coverage for gender-affirming care and gender-affirming treatment look like. So I'll stop there. I'll get off my soapbox. I hope at the end of this, I'll look back and realize I had no need to say that at all. But just wanted to make sure we covered that ground. So, Karen, if you can move to the next slide. So I just want to start with a real quick, just sort of an overview of rulemaking, and then I'm going to transition that into a review of the provisions of House Bill 2002. So if you've been part of a rulemaking I've hosted before, usually the first meeting is kind of a lot of exposition. I'm going to talk a lot today, particularly in the first half of the meeting. But I think it's worth going through this just to kind of ground everybody in what House Bill 2002 says, what is the specific language, because at the end of the day, that's sort of what we as a Rules Advisory Committee have to work with. But for anyone who's, I'm kind of assuming most people are familiar with rulemaking processes, but if you're not, the reason we're all here is Section 20 of House Bill 2002 requires the Department of Consumer and Business Services to adopt rules implementing the provisions of Section 20, which is essentially the insurance provisions on gender-affirming treatment. So what is a rule? Well, there's sort of a long definition under ORS 183. Starts with any agency directive, standard, regulation, or statement of general applicability that implements, interprets, or prescribes law or policy. It goes on to have a whole bunch of things that aren't rules. If you're interested, you could look at the statute, but kind of the two key things to know is that the rules that come out of this process ultimately will hold, it is a lawmaking activity, right? These rules will have the weight of law. And normally it's the legislature that makes laws, but in our case, essentially the legislature has delegated a portion of that authority to us. And that means that any laws that we adopt, or any rules that we adopt must be consistent with statute. So in our case, while we do have a pretty broad rulemaking grant, we do have to sort of stay within the boundaries of House Bill 2002. Next slide, please. So real briefly, the role of the advisory committee. If you think about rulemaking as sort of like a I don't know, a football game with like 4 quarters. We're kind of in the first quarter. We're somewhere maybe about halfway through the first quarter. So the goal of the idea of the Rules Advisory Committee is you bring together sort of diverse interest of people who are likely to be affected by the rules, right? And you bring them together in sort of a collaborative fashion to provide advice and recommendations on a set of proposed rules. So at the end of the committee process, we should hopefully have something approaching a consensus draft, which we as an agency will then take into a formal rules adoption process. So that while this is a public process itself, the actual adoption process involves publishing a formal notice in the Oregon Bulletin, having a public comment period that's open for a period of time, and that includes a dedicated public hearing where we as the division will take public testimony and commentary. Part of why Oregon does the advisory committees is the hope is that by the time we get to that hearing, all the issues have been vetted here and raised. And so hopefully that hearing won't be particularly controversial or lively. Our goal is always, in the ideal state, no one comes to testify because everyone feels like their issues have been addressed already. But I just want to flag that this is sort of, when we get through this, there is still more process to come. And there will be opportunities for comment even after the committee ends its work. Next slide. So now, just want to turn to sort of, I'll kind of walk through what I think of as sort of the key and really significant pieces of House Bill 2002 when it comes to gender affirming treatment. You'll see these again kind of when we get to the rule draft, but right now I'm just focusing on the language in the bill. The language on the screen should mirror exactly what's in the bill. So first point I want to raise is sort of the definition of gender affirming treatment. Under the bill, gender affirming treatment means a procedure, service, drug, device, or product that a physical or behavioral healthcare provider prescribes to treat an individual for incongruence between the individual's gender identity and the individual's sex assignment at birth. So that is the statutory definition. You'll notice when we get to the draft rules, essentially we are just referencing back to this definition. Key thing to note here is this is a very, very broad scope of potential services, right? This could be a lot of things from physical or mental health, and a lot of different services could fall within sort of this umbrella term of gender affirming treatment. So this is a very broad breadth of possible services we're looking at. Next slide. So sort of, I'm kind of going to walk through what I think of sort of the key requirements of House Bill 2002. And the first one is relatively straightforward. It says a carrier offering a health benefit plan in the state may not deny or limit coverage under the plan for gender affirming treatment that is medically necessary, as with that to be determined by the physical or behavioral health care provider who prescribes the treatment, and that is prescribed in accordance with accepted standards of care. So essentially the idea here is if these two criteria are met, the health plan should be covering the service. When it comes to standards of care, I mentioned WPATH 8 earlier. That is something that through the legislative process, it was sort of, I think, understood among both the sponsors of the bill and the industry that sort of the lodestone here, and you'll see that in the draft rules, is the WPATH 8. That's a fairly new standard, came out, I believe it was October. I believe it's a little bit more than a year old. I think it was published last October. And that's a pretty significant, it's very thick, a lot of research and a lot of information. And it's a considerable increase in terms of the sort of the items and services covered and addressed and the issues talked about relative to the previous version, which was the 7. So if you're familiar with the 7 and you're not familiar with the 8, you're going to want to get familiar with the 8. Sorry, I lost my train of thought there. So we'll be talking more about that. We'll kind of probably do some deep dives. For today, I just kind of wanted to cue that up, that the WPATH 8 is part and parcel of, and I think that is where the division is intending to go, is to recognize the WPATH 8 as among the accepted standards of care. Next slide, please. I should mention too, while I'm kind of doing a lot of talking, if there is anything, folks, as I'm talking through this, if anyone has anything they want to talk about in terms of at the level of the bill that I'm either maybe not covering, or they want to make any points, please feel free to raise your hand and chime in for the committee members. But so it's so the first requirement on the bill is sort of you can't deny or limit essentially medically necessary gender affirming treatment prescribed in accordance with standards of care. Second part is there's sort of almost duplicative language in the bill under sections 2B and 2C that basically both kind of get at this idea of prohibiting blanket exclusions. So 2B says carrier offering a health benefit plan state may not apply categorical cosmetic or blanket exclusions to medically necessary gender affirming treatment. And sub C, although C goes on, and we'll talk about that more in the next slide, but I just want to note that the initial part of C says, similar to B, it says, carrier may not exclude as a cosmetic service a medically necessary procedure prescribed by a physical or behavioral healthcare provider as gender affirming treatment. I kind of wanted to put these two parts of the statutes together just to make the point that, at least from kind of our perspective as the division, when I read this, I don't see a lot of difference here between this part of B and C. Or maybe another way to put it is, I can't think of a thing that C would prohibit that B would allow, or vice versa. So, and that's relevant, I think, when we get to the rules. I think we can maybe condense this down a little bit, just in terms of, I'm not so sure these are necessarily separate requirements at this point of the statute. Next slide. Point to make here. So this continues on. So this is the full text of subsection C. And it goes on. So in addition to saying you can't exclude as a cosmetic service medically necessary procedures, it specifically calls out 5 things here. And I just wanted to mention that because I think that's interesting that the bill called these out, and they may be things we want to spend a little bit of extra time in as a committee thinking through. The first 3 here are basically specific procedures. So it's tracheal shave, hair electrolysis, and then facial feminization surgery or other facial gender affirming treatment. And then D gets into, says you cannot exclude as cosmetic any revisions to prior forms of gender affirming treatment, or under E, any combination of gender affirming treatment procedures. So just kind of wanted to highlight this language because I think we could probably spend a little bit of time on each of these as we move forward. Next slide, please. So the next big thing in the bill, and I would say these things sort of get a little bit harder as we move through each one. We get into 2D, and it says a carrier offering a health benefit in this state may not issue an adverse benefit determination denying or limiting access to gender affirming treatment unless a physical or behavioral healthcare provider with experience prescribing or delivering gender affirming treatment has first reviewed and approved the denial of or the limitation on access to the treatment. So this essentially kind of, at least how the division is sort of interpreting this, seems to contemplate something of sort of a pre-approval, right? That if you're a carrier and you've gotten a claim for gender affirming treatment and you're intending to deny that claim, you have to consult with a healthcare provider with experience in gender affirming treatment before you issue that, and that provider has to review that and approve it. I think one of the big questions from talking to stakeholders, and I've already gotten this question, is exactly what does that mean to be a physical or behavioral healthcare provider with experience prescribing or delivering gender affirming treatment? So without sort of getting into the substance of that, I just want to cue that issue up, that's something I think the committee is going to want to take a look at, is exactly who needs to do that review and who can do that review, and what does it mean to have experience. Next slide. I also wanted to flag with respect to adverse benefit determinations, that is a term of art in the insurance world. So it's a very specific thing, and it really became a primary issue under the Affordable Care Act, which created requirements around notices of adverse benefit determinations. So the idea here is essentially it largely gets at denials, but we do have a definition under state law that is something we might want to look at. And if you look at all the things that are part of that, we kind of might want to think through exactly what the nature of the requirement under House Bill 2002 is, and which and when sort of a given adverse benefit determination needs to be reviewed. We'll talk about this when we get to the rules, but one of the things we noted is I think that's debatable if this is true under state law, but at least under federal law, it's pretty clear that even if a carrier just applies cost sharing to a service, in other words, it's covered, but maybe subject to deductible or other cost sharing, that's an adverse benefit determination under federal law. So I did include a little bit of language in the rule to clarify that I don't think those are that type of adverse benefit determination is one where we need to have that reviewed by an independent healthcare provider. Maybe I shouldn't say independent there, a healthcare provider. But I just kind of wanted to cue that issue up, that we may want to look a little bit into exactly which adverse benefit determinations, or sort of what does that term mean in context of House Bill 2002. Next slide, please. And then this is sort of the last big sort of substantive requirement of House Bill 2002, and it's something else I think we're going to want to spend some time and a lot of thought on in the committee. And this has to do with network adequacy. And this is a little bit tricky how this is worded, so I wanted to spend a little bit of time on this. So this section says a carrier described in subsection 2, which essentially meaning a carrier offering a health benefit plan must. There's an and an or here. So the first part is carrier must satisfy any network adequacy standards under ORS 743B 505 related to gender-affirming treatment providers. So that is sort of referencing our general statute on network adequacy. I would have included the text of 743B 505 in the presentation, but it's very long, and I ended up having to put the font size so small it just would have looked silly. But we can look at that statute as a committee, and I'll make sure that we get copies out to folks. But just want to flag that sort of requirement 1 here is that you have to comply with any to the extent that anything we adopt under 743B 505 relates to gender affirming treatment. That is also that is going to apply to carriers as well under House Bill 2002. But this ends with an and. So if we can go to the next slide. I think this kind of gets at the real meat and sort of the substance of what's sort of new under House Bill 2002, and this is an or statement. So this is a carrier offering a health benefit plan must, and I'm going to add the either, A, contract with a network of gender-affirming treatment providers that is sufficient in numbers and geographic locations to ensure that gender-affirming treatment services are accessible to all enrollees without unreasonable delay, or the alternative is ensure that all enrollees have geographical access without unreasonable delay to out-of-network gender-affirming treatment services with cost sharing or other out-of-pocket costs for the services no greater than the cost sharing or other out-of-pocket costs for the services when furnished by an in-network provider. So the idea here essentially is that option A is that you have essentially a network that is sufficient enough that all enrollees are able to access services, or provide, essentially, I think what the idea here is, make that care available from an out-of-network provider with the caveat, essentially an out-of-network exception, where you'd say, yes, this provider's out-of-network, but we would cover it in a way that the members' cost sharing and out-of-pocket costs are no greater than they would be in-network. This is This is going to be a tricky statute that I think we're going to want to spend some time in thinking about, and I think it's going to require us to kind of come to understand how network adequacy works now for commercial health plans, just generally, which is already sort of a little tricky, and then sort of a specific application of it in context of gender affirming treatment. And I think one of maybe several things that make that particularly tricky is we're going to have some way of identifying who is a gender affirming treatment provider, and sort of, I think this is sort of similar to the previous piece about who can be reviewing the adverse benefit determination, but there's some attention here to, if we're saying specifically gender affirming treatment providers, who are those, and what does it mean to have a sufficient number of those? I'm going to pause there and just open it up to committee members. If anyone has, that's sort of my summary and kind of from the division's perspective, how we've been looking at the bill and thinking about it. But I just kind of want to open it up there to see if anybody wants to add or comment on that generally, or just has anything they want to add there. Rick Blackwell.
Rick Blackwell with Pacific Source. Michael, in the section 20, there's the definition of gender affirming treatment says that that procedures, devices, drugs, products, etc., that a physical or behavioral health care provider prescribes is what constitutes gender affirming treatment. Has the division looked at whether that altered any scope of practice requirements? Because I was thinking as I was prepping for this, I would think, although I don't know this, that some behavioral health providers might not be able to prescribe it might be out of the scope of their license to prescribe certain devices or procedures. I don't know this. I just want to make sure that we have that clarified, though, because there may be some places where, we just want to make sure we're clear on that point.
In the sense that the bill doesn't specify within scope of, it doesn't have any language or clause like that it says within the scope of that provider's license or something. Is that the point?
Yeah, right. Yes. Got it.
Yeah, that's I mean, to answer the question you asked, I don't know that the division has thought about that. I don't think the bill would or could alter scope of practice. Just sort of for my own purposes, when I thought about it, I guess I assumed that it meant, when they're talking about it prescribed by a healthcare provider, mental or physical healthcare provider, that in order for them to prescribe it, it would presume that service was within their scope of license to prescribe. Like, it was not authorizing an expansion of that scope of license, but that may well be something we should think about and clarify in the rules. I think that's a valid point. Anybody else? Just kind of at the level of the bill at this point before we sort of dive into the rule draft. Marianne Cooper.
And Michael, if I can't talk, let me know, because I'm filling in for Antoinette. So hopefully I'm allowed to speak, but stop me.
Yeah, it might be helpful. Just to clarify for everybody, Marianne is, Antoinette is actually the committee member for Regents, but she was only able to attend for about the first half hour. She had to get on a plane. So Marianne is sort of sitting in for Antoinette for the remainder of the meeting. But go ahead with that clarification.
Thank you, Michael. I just wanted to clarify, just because I know several of us were in a meeting that occurred with the Speaker's office and some of the carriers and some of the advocates for the bill, particularly around these network adequacy requirements, that, both, I think we will need to address. One, for, some people, there may not be gender affirming treatment providers that are geographically close to them. And so I think for, depending on the care that's required, there may be some travel inherent in that. And I know that we had kind of agreed in the Speaker's office that would be addressed. And then I do think similarly, in terms of how it is viewed, this is a network of a lot of different providers that can all provide gender affirming treatment. And so making sure that we're talking about, specifically what treatment is it, and what level of expertise somebody would need to have or experience you need to have to provide gender affirming treatment. I know I shared in the meeting with the Speaker's office, we keep a list of providers many of whom have asked, not to have it published publicly on our website, but to have it made available for members to call in and ask for referrals to providers who can provide that care. But, since gender-affirming treatment is not itself a specialty, but rather kind of a subset of a number of different specialties, I just think, like you said, we're going to have to spend some time on what that looks like. But I feel like there was kind of broad acknowledgement and commitment in those conversations within the legislature to ensure that we handled that kind of in an appropriate way and in a way that accounted for all of those considerations.
Yeah, those are, I think both of those concepts are on the division's radar. Yeah, I'll kind of talk about them in the order you laid them out. So kind of the first point there, and this arises with network adequacy generally, right? Is a provider, or excuse me, a carrier's network can only be as broad as there are providers available, right? So one of the other complicating factors around network adequacy in this context, I think, is getting a sense of how many providers are there for all the different services that could fall under sort of that umbrella of gender-affirming treatment, right? Because I'll say it this way, it would probably be a mistake to adopt a rule that required a carrier to contract with more providers than there were in the state, right? So some part of this has to sort of, you have to sort of think about it from a supply and demand standpoint, I suppose, that, you have to have the providers available to contract with. And there has to be, it doesn't really do us any good to just, fine a carrier for having an inadequate network if they don't really have the ability to control it. So that's sort of point one. So go ahead.
Michael, there's also significant wait times across all carriers or across all providers right now. And so, I think also factoring in what's the reasonable and unreasonable delay. And also relatedly, I know we raised this in the meeting with the Speaker's office too, if there is kind of a force, you have to be contracted with 100% of providers of these services, that can have a real impact on affordability for both consumers and, our ratepayers at large. And so I think just all of those things are ones we'll want to factor into this rulemaking, and they were all kind of raised, and I think some broad agreement that we need to work through them as the bill was moving through.
Correct. Yeah. Understood. Yeah. Recognizing too, just to kind of get the counterpoint, not to go back and forth with you, but the other side of it, of course, is if there's not it, I think there's some element of a desire to create that incentive for carriers to contract with these folks from the standpoint of helping them, getting them out there. Like no one is going to go into this field if they know they can't get a network and can't get reimbursed. But I absolutely take your point as well, right? This is sort of the trouble of network adequacy, right? And on the second point, I think you raised, just to kind of highlight that a little bit, I've said this to a couple of people now, but I'll just say it for the group, is when it comes to sort of saying that the number of gender-affirming treatment providers, it's a little tricky to figure out exactly who that is, right? Because I have been assuming that the number of providers who, sort of actively practice, you would think of as in, providing gender-affirming treatment is probably smaller than the number that by license could provide gender-affirming treatment, right? So I think there needs to be a sort of an extra sort of look there too. It's not just a provider type, but it's a provider type that is doing this. And we, as you said, we don't have sort of a bright line test or a board specialty to just sort of look to. So that does make this tricky. Anyone else have thoughts on any of that? I kind of talked a lot. And from my perspective, those are the challenges, right? So I just want to be, transparent about those issues, while also recognizing the need to give this provision meaning, right, and implement this. All right. It is about 1:53 and not seeing any hands. So I think it probably makes sense at this point to just sort of why don't we go ahead and take a short break, I could use a break because I just talked a lot. I know you all have been sort of sitting there. But why don't we go ahead and take about a 10-minute break here. And I'm going to go get a drink of water and go off camera, and we'll come back and we'll pick up with the rule draft. I don't have any slides on that, so we can stop sharing the screen and we'll just kind of open up some conversation and walk through the rule draft. I'll try to give kind of our perspective as a division of what's in there. And then hopefully, you know, we can start open it up to some commentary and some thoughts about what's there, what isn't there, and what needs to be there. So we'll take a break. Thank you all. Yeah, let's come back at 2:05, everybody, just to confirm.